patients in Palestine, they were using combination therapy. They were not using one antipsychotic at a time. They were even given combination therapy from day one of their schizophrenic episodes. But we are not alone who are using the antipsychotic combination. Different countries, they are using this combination against the recommendations and against the guidelines. But we are much more than USA, China, India, Canada, but thanks God, Nigeria is more than us. 92% of the patients there, they receive combination therapy. Not only the patients were using combination therapy, we found that only 42 of the patients, they received the adequate dose. 35% of the patients, they received underdose, and 22% of the patients, they received overdose. The prevalence of metabolic syndrome was found in 43% of the patients. More than 43% of the patients, they were suffering from metabolic syndrome. In a study done by Abdurrahim et al., it was found that the metabolic syndrome, as it was defined by the WHO, the prevalence of the metabolic syndrome in West Bank of Palestine was 17%. In the general population, the metabolic syndrome prevalence is 17%. Of course, the age was adjusted. But here, in our sample group, in schizophrenic patients, the metabolic syndrome prevalence was 43. The metabolic syndrome was common among male and female. The female patients, they were even, the incidence of metabolic syndrome were more in females than males. We could not explain it nicely. The metabolic syndrome was also, the incidence was increased with the duration of the disease as expected. Of course, the metabolic syndrome prevalence and incidence were found even in those patients who received the accurate dose. Even those who received the accurate dose, they develop metabolic syndrome. We made 10 years calculation for developing CHD. We use the Framingham equation, and as you can see, the 10 years risk of developing CHD increased significantly with the duration of the disease. Of course, the dose also play an important role in developing the 10 years risk for coronary heart disease. So the question, medication or the disease? We should keep in mind the metabolic syndrome. We should keep in mind 10 years risk for CHD. So this here rises the question, is the cure worse than the problem or not? And as you can see here, the physician is telling the patient when the side effect of this medication kick in, you will forget what was wrong in the first place. The recommendations, we recommend to implement the guidelines for the treatment of schizophrenia and stick to recommendations and guidelines. We should monitor the health of schizophrenic patients regarding developing of diabetes, hypertension, lipids, and obesity. Research in the mental health in Palestine and Arab world should be supported and encouraged. This is our research team, and thank you.
I have one question in the back and then over here. Please go ahead.
Thank you for the presentation. You were kind of either implicitly or explicitly implying that metabolic syndrome is like caused by antipsychotics. I mean, this was kind of like a cross-sectional study. It's not a longitudinal study as far as I can tell. So can you please shed some light on that? I mean, we all know that metabolic syndrome is of course, can lead to CHD. But what does that have to do with the use of antipsychotics?
Antipsychotics, it is reported in the literature to have side effects on them in developing the metabolic syndrome. So we say that the metabolic syndrome is caused by the use of antipsychotics because we compare the development or the incidence of metabolic syndrome between the general population who are not receiving any type of medications with those patients who are receiving the antipsychotics. So the development of antipsychotics could be due to the use of antipsychotics, but there are still other factors they could contribute to the development of or to the incidence of metabolic syndrome in these patients, because it is also reported in the literature that the schizophrenic patients, they are neglected, they have poor lifestyle, they are smokers, they are unemployed, they take more carbohydrates than proteins, they are obese in general. So it could be due to the antipsychotics, it could be due to the lifestyle and the nutrition of the patients, but we think and what we found in our study that even those patients who are thin, not obese, not overweight, even they have the metabolic syndrome.
I'm sorry. But yeah, as you
Over
just
here
said-
first, please.
Yeah, I just had a comment.
Maybe afterwards, for the sake of time, we have 2 more questions now, so we'll go here and then.
I'm aware, even from the American Diabetes Association, that the risk factors for this condition is for second-generation antipsychotics. So, have you differentiated between patients have taken third-generation versus the second-generation antipsychotics?
No, we did not categorize the patients who are taking antipsychotics first generation and second generation because patients, they are not stick to the medications. So sometimes you will see the patient taking the first generation antipsychotics. So on the second month they take the second generation antipsychotics. It depends upon the availability of the drug at the Ministry of Health, because antipsychotics are given free from the Ministry of Health to the patient. So whatever the antipsychotics are available, they are giving to the patient. And this was one of the problems.
I think you will take one more and then we'll call.
You should follow the guide. It depends upon the case. Some people, they respond well to the first generation. Some people, they don't. So you go for the second generation. If, even according to the WHO, if none of them work alone, you can use the combination.
I think side effects is the major issue. It's when it's second generation or third generation antipsychotic. Usually we start with second generation, and if no response, we add the third generation antipsychotics. And side effects is more.
Thank you, Dr. Iyad.
Thank you, Dr. Iyad. Our next presenter is Mr. Bilal Saleh. Bilal Saleh is a lecturer at Al-Quds University, Faculty of Medicine. He has an MSc in clinical pharmacy, and he was a member in developing rational use of medicine and standard treatment guidelines and therapeutic protocols for governmental hospitals in Palestine.
السلام عليكم جميعا. Okay, let's start. Thanks for joining me today. I would like to talk about a valuable topic that has really strong impact in our profession, which is medication error, minimizing medication error, health information technology, and pharmacist role. I will focus mainly, basically, on the methods to reduce medication errors. The flow of the contents will be as follows. I will define medication errors, then intro and a sort of statistical data, and then causes, reasons, and risk factors. Then a list of the most common medications involved and the reason behind this. Then methods of elimination and prevention of medication errors. And the last part will be about some issues in the news, some promising news. Now, the National Coordinating Council for Medication Error Reporting and Prevention defined medication error as any preventable event that can cause or lead to inappropriate medication use or patient harm. By intro, medication errors are significant concern and may lead to serious medical problems. Medication errors problems are expensive in terms of financial burden and may cause deadly or we can say life-threatening conditions. Every healthcare provider should take his responsibility in order to minimize medication errors, and pharmacists in particular should take the responsibility to reduce medication errors and should follow the advancement in literature in order to decrease medication errors. A pharmacist would be hard impressed to imagine anything being worse than making or responsible on an error. Global prevalence of medication error, really it's not possible or it's impossible to establish a global rate for medication error. But there are some reflective or expressive studies. In a study carried out by the Institute of Medicine, the IOM, inpatient medication error rates from 4.8% to 5.3%. And in another study carried out also by the IOM, the Institute of Medicine, medication error can cause 1 out of 131 or 131 outpatient deaths, or 1 out of 854 inpatient deaths, and these are huge numbers. The US prevalence, it is estimated that 25% of all adverse drug events could be preventable or could be as a result of medication errors, and this may harm 1.5 million Americans annually, and this may lead to more than 7,000 deaths each year. This is a huge number. The morbidity and mortality for medication errors cause also a large number, around $77 billion a year. And the last estimation, at least one medication error occurs per hospital per day. In a commonly cited study, 50 community pharmacies, medication errors can cause 1 in 1.7% of prescription filled, and this may present around 6.5% of them clinically significant. And there are about 20% of critical care medication errors are life-threatening. Medical errors in general, this is medical, not medication, the last point. Medical errors are the third leading cause of death in USA. Let's go back to our province, the Middle East countries. It's difficult to imagine the figure in Middle East countries, and the studies are poor and few in number. But the objectives of a systematic review carried out in 2013, the study's objectives were the incidence and types of medication errors and the contributing factors involved. Okay, the results were as the following. 45 studies met the inclusion criteria. And the error rates from 7 to 90% for prescribing, and from around 9 to 80% for administration. The most common type of medication errors were around incorrect medication, wrong frequency of administration, or wrong strength. And as I said, the medication error studies in Middle East countries were poor in quality and few in numbers. FDA reports, medication errors reported to FDA adverse event reporting system, around or more than 5,000 reports in 5 years. These were in five years. 2/3 of them were serious, and around 10% were fatal. But the actual number could be more than this, because the reporting system in the FDA is voluntary. So the actual number could be more than this number. Causes and risk factors, we have list of causes and risk factors, but I think the most important ones, those are in blue color. The workplace environment, which is the most important factor that can lead to medication error, and non-adherence. And in a previous study, around 50%, just 50% of patients adhere to medication over time. The workplace fatigue factor, workload in different studies represents the most effective or significant factor for causing medication error. And based on the US Army studies, staying awake for about 17 hours equals blood alcohol level of 0.05%. This is amazing. And staying awake for 24 hours equals around 0.1 blood level of alcohol. And the California Pharmacy Association launched that less than 15 prescriptions per hour should the pharmacy prescribe. The most common medications involved and the reason behind, different studies available, and as a result, 47% of errors involved 7 drugs or drug classes. They were the following: warfarin, digoxin, opioids, methotrexate, beta blockers, aspirin, and NSAIDs. Note that warfarin and digoxin, they have narrow therapeutic window, and this is the reason. Okay, opioids and methotrexate, they have already serious side effects, and the others, they could have cardiovascular side effects, and that could be the reason behind what we are talking about. Elimination methods, errors will occur and will always occur, and it's not possible to eliminate all errors. Mistakes are the stepping stones to learning, and we all know that mistake is the best teacher. Attitudes about medication errors. Who was involved in medication error is of less importance than what and how and why the wrong happened. So the Academy of Medication report believes that establish a non-threatening and non-punitive treatment and non-punitive management for medication errors. And we have to report errors. Reporting systems available in websites. Okay, the ISMP reporting system and the FDA mid-watch reporting system, and they are voluntary. Okay. Punishment and blaming an individual does little decrease medication error. So we have not to depend on this style to punish and to blame an individual who is responsible for the error. Instead, we have to develop a system. Steps to reduce medication errors. Pharmacovigilance Risk Assessment Committee established that there are 2 steps to it. Number 1, vigilance or pharmacovigilance is the most important part. Then appropriate suitable technology. In 1999, the IOM, the Institute of Medicine, launched a report called To Err is a Human, Building a Safer Health System. And this report was important in order to decrease medication errors, to know the most important errors available and to decrease them, or at least to decrease their consequences. These are steps according to pharmacist role. I think the most important ones are reporting errors, then counseling. And counseling should depend on different kinds of communication skills. For example, the teach back method, or what's called show me method. It means asking the patient to explain in his own words. Okay? Then the icebreaker questions or the direct questions. Don't use abbreviations. Don't use error-prone abbreviations. There are available lists of abbreviations and they are frequently updated. These abbreviations may be responsible or may cause harm to the patient. The best approach, target the system, okay, not the individual. Don't rely on human alertness. System, we are talking about the most important system nowadays, health information technology. And the health information technology is a broad concept. It's a broad concept. Its components for health information technology are electronic health records, CPOE, which means physician order entry, computerized physician order entry, and e-prescription. Health information technology benefits. In a study, the use of CPOE, computerized physician order entry, and barcodes may reduce errors by more than 55%, which is a huge and large percent. E-prescription, traditional orders such as verbal or handwritten orders, 30% require a call to the prescriber. But in case of e-prescription, we can omit this percent. Because drug history is available here, patient profile is provided, and we can link the data, minimize dosing errors, and enhance for screening for drug-drug interaction, enhance for patient allergy, etc. Disadvantages of e-prescription. Every system introduced to decrease error has its own problems and has its own errors. For example, in 2014, a study carried out and showed that wrong drug quantity represents 40% of errors. 40% of errors according to e-prescription, and wrong duration represents 21%, wrong dosing 19%, and wrong formulation around 11%. In the news, and these are promising news, hospitals put pharmacists in the emergency room to cut medication errors. Pharmacist error rates rises as workload declines, and this is a new study carried out in 2015. And the most important and the good news, we said in the beginning of the presentation that there are more than 7,000 deaths every year in USA based on medication error. Now the good news is that there is movement, a patient safety movement, trying to eliminate all deaths by 2020. Thank you for listening. Any questions?
Question, please go ahead. Comment?
I think
Short.
one of the main reasons for medication errors is that we want to use a redundancy system. Redundancy system is that everyone that receives a prescription should check for errors. We all claim the prescriber, so we have errors. We see an error as being 1%.
Okay, that could be in developing countries mainly, I think. Thank you, Muhammad. Another question?
Sorry, please go ahead.
First of all, I think we need to differentiate between adverse effects and medication errors.
Yes, okay.
Because I I saw some mixing,
overlapping between
also between adverse effects and medication errors, and consider that adverse effects are medication
Okay.
errors sometimes.
Okay, no, I said that the preventable adverse drug events, mostly they are medication errors. The preventable ones, mostly they are medication errors. Okay, but yes, there is a difference between them. Yes.
When you talk about drug interaction, polypharmacy, these are not always considered to be.
Yes, okay. Yes, okay. That depends on preventable or the most preventable adverse drug reaction. Thank you.
Thank you very much.
Okay, thank you for listening.
I believe our next presenter is Dr. Juan Al-Khayari. Dr. Juan is currently, she holds a master's degree in science in pharmacy with specialization in pharmaceutical technology. She's the head of good governance for medicine section of the Jordan Food and Drug Administration. She worked as a pharmacist, I believe, in Erbil and other places. And she is representing the Hashemite Kingdom of Jordan in many international conferences and workshops as speaker and trainer in good governance, moral leadership, and related issues. So, welcome.
Good afternoon, everybody. First of all, I would like to thank Zaytuna University for conducting such important conference, and I would like to welcome all the guests from all over the world and wish you an enjoyable stay here in Jordan. Now we are working in Jordan to implement the good governance for medicines in the pharmaceutical sector. Actually, we start our work by an initiative from WHO, and now we are working to implement and work on this issue and governed by the government of the Jordan. I will talk in brief about the Jordan health and pharmaceutical sector, the stakeholders, and the GGM phases. First of all, we know that the Jordanian pharmaceutical industry is a reputable industry here in Jordan. We have about